I can't stand these things over here. First, I want to thank Mike for organizing this. He did a remarkable job connecting all the different pieces. And I want to also point out that all the profits from my book go to Doctors Without Borders, so that if you purchase one, it will be benefiting a great relief organization around the globe. And feel free to post anything you want on social media about what I say, because the people in this room understand the power of generative AI and AI in general, but the people outside the room, a lot of them don't. And that will be our focus today. So let me start by asking you, if you knew that your car would go as fast as an airplane in 5 years and as fast as a rocket ship in 10 years, how would you approach it? Would you worry about how fast the cars were going to go and the traffic that would happen? Or would you start thinking about different ways that you could live in Hershey, Pennsylvania, and work in New York City, or live in New York and work in Hershey? Or, you know, how would you think about things differently? Where would you put hotels, restaurants? You would have a very different view. One of the challenges of a generative AI tool is that it doubles in power every year. Also the big opportunity of generative AI. That means that in 5 years it's 32 times more powerful, in 10 years it's 1,000 times more powerful. Don't think about what exists today as generative AI. Think about what's going to be here in 3 to 5 years. And when you start to do that, you have a very different view of the world. Give me a second. You start to have a very different view of the world, and you start to realize that what it can do is it can save hundreds of thousands of lives every year. It can make American medicine affordable for all people. It can relieve the burnout that's afflicting doctors today. I think it's important that you start with all of medicine's failures. You know, everywhere I go, I speak. I've all spoken probably at 40, 50 conferences over the past 6 months. Everyone worries about AI's problems. How about medicine's problems? How about 400,000 people dying every year from misdiagnoses? Another 400,000 disabled from misdiagnoses. How about 250,000 people dying every year from preventable medical errors? Medication errors, hospital-acquired infections, pneumonia in intubated patients. How about the fact that we spend twice as much as any other nation in the world on healthcare, $14,000 a year. Switzerland's about 10,000, Germany's around 9,000. Everyone else is half of us. And amongst the 12 peer nations, according to the Commonwealth Fund, we're last. We have the highest number of preventable deaths. We have an age discrepancy between us and the other 11 nations that used to be 4 to 5 years during COVID. It's now up to 5 to 6 years, because the rest of the world's recovered from COVID. We have only recovered about halfway. I could spend the entire 45 minutes we have talking about the problems. But let's not talk about the problems. Let's look at the opportunities that exist. And it's a little hard to say what I'm about to say when the person organizing it's a radiologist, because I'm not going to talk about radiology, except very briefly. And I want to highlight that we should never use the word AI again, because there are different kinds of AI, and each one is completely separate, except for the fact they all use a computer. It's like the apps on your phone. They're all different. Not that they're more valuable or less valuable, but they just have different applications. You trace the history of AI, you go back to the 1980s, actually to Stanford, where what you find is that they had what's called rules-based AI. The way a rules-based AI works, and there was a program called MySyn that was being done to diagnose and to recommend treatment medications for infectious disease, is that you take an expert, and the expert provides the set of heuristics, the rules of thumb, 5 or 6 different ways that diagnoses are made. You look at a pathology slide and you see a lot of weird looking cells and a lot of mitosis, and it's invading tissues, not pushing it away, and we call that cancer. But what we know is that heuristics, these shortcuts, are not fully accurate. What we know is that these shortcuts can be beaten by a clinician with intuition and experience. And so despite the fact that rules-based AI existed for about 20 years, very little application of it happened. And then around the year 2000, we see a shift. What we see around the year 2000 is that the architecture of AI tools started to take a biological structure. You see neural nets, you see multi-layer connections between the different parts that are sitting there. The way a narrow AI tool is done is by taking two data sets and having the application compare the two, find not 4 or 5 differences, but maybe 50 or 60 differences, and then using probability theory, assign a value to each, and out of that be able to come to a conclusion. A great example in radiology is mammography. Mammography is a very difficult specialty. Human beings, by the way, only get it accurately about 80% of the time, and I say that because if you take a group of radiologists, they will have that much discord when it comes to mammography reading. And what it does is that maybe 5,000 have cancer, 5,000 of the mammographies, of the mammograms don't. They're normal or benign disease. And then the application finds the differences between the two, ones that often the human eye or the human brain can't comprehend. And out of that is able to come up with a reliability reading that is, some would say, 10% better than humans. There's 1,000 of these narrow eye applications approved by the FDA, and almost every one of them is in a visual field. Radiology, pathology, retinal scans for ophthalmology, dermatology. Now, why is that? Why did Watson fail to be able to use the narrow AI tools to be able to use information from the electronic record and be able to make optimal diagnoses? And the reason is that what a narrow AI tool does is magnify differences. And so it can find things in visual images, because two pictures, assuming they were taken under equivalent light and other characteristics, and by the way, there's a lot of racial issues that are problematic because human skin is a different color, but we'll skip that for the time being. And being therefore able to make an accurate conclusion. But the electronic health record is not accurate. And so it amplifies not just the differences, it amplifies the mistakes. I see a patient and I say the patient has a pain level of 6 on a scale of 10. Michael sees a patient and says has a level of 5 on a scale of 10. Whose patient has more pain? We have no idea. We have no idea because it relates to two human beings, the patient and the doctor. How does the patient evaluate their pain? How does the doctor evaluate the pain? And that is the problem that exists. And that doesn't say anything about other copying and pasting and other reasons why the electronic health record is an inaccurate document. Generative AI is completely different. I remember the first generative AI tool that was released only happened in November 30th of 2022. Again, very early, with the dawn of this. I call my book ChatGPT MD, and by the way, I have no conflicts of interest. I have nothing to do with ChatGPT, OpenAI. I just like 5 letters in a row, GPT MD. So that's why the book has that title. And by the way, the subtitle is How AI-Empowered Patients and Doctors Can Take Back Control of American Medicine. I want to emphasize patients first. I challenge you to tell me a single tool developed in medicine that is being used for the patient, not for the doctor. This is the first tool that creates expertise. not just for the clinician, but for the patient. And it's going to be very important when we talk about how we're going to address the economics, the quality issues, the inequities. We could go down the list of problems in medicine. So how does generative AI work? And again, although we call it GPT, it's really PTG. P is pre-training. These models have been trained on the totality of medical information. In fact, all information, everything on the internet, everything that can be scraped off, every textbook, every article. And having been pre-trained on that, then it's given parameters, billions of rules, but not rules specific to the heuristics, like in the rules-based AI, but rules related to relative value. A more recent article is more valuable than an older article. An article from a peer-reviewed journal is more valuable than one from a non-peer-reviewed journal. One from a leading academic institution is more valuable than one written by a single individual who maybe doesn't have the background training, statistical ability to be able to do a proper study. And out of that, it generates an answer to any problem. I hope that everyone in this room has at least tried one of the generative AI tools. It could be ChatGPT, it could be Gemini from Google, it could be Claude from Anthropic, maybe even DeepSeek coming out of China right now. And I'm going to speak about DeepSeek a little bit more because it's an open source generative AI tool developed by Distillation, and that's going to change what happens over the next 3 to 5 years. But I'm getting a little bit ahead of myself. So let's go back now to the generative AI tool. It can allow you to paint a picture that looks like a Rembrandt, even though you never took an art course. It can allow you to program a computer, even though you never had an IT course. It can allow you to create a song that sounds like Drake and The Weeknd, even though you don't play an instrument. And it allows people who are never been to medical school to make accurate diagnoses without the assistance of a physician. And I don't mean today, although we'll do it today, by the way. I mean soon. Highly reliable. I have my own podcast every week called Fixing Healthcare, but I also speak at a lot of other people's podcasts. And I was at a program recently, at the end, after I finished having the interview, the woman said, "Dr. Pearl, you're a skier, you're a doctor. My husband fell about 3 months ago. His arm was over his head, he slid about 100 feet. His shoulder hurts, his arm doesn't work as well as the other side. What's going on?" I said, "I think I know exactly what he has because I'm a skier and I know exactly the injury, but you said you never used ChatGPT. Use the free version, don't bother paying for it. Put all of his information in place and see what happens, and then call me back and I'll tell you what I think." 5 days later, she calls me back. She said, ChatGPT said, number one, he probably had a rotator cuff tear. Number two, he needed an MRI. And number three, he should see a surgeon because he almost definitely needed surgery. Now think about that compared to clicking on a link on Google. You could get 100 different differential diagnoses of shoulder pain. You could get 100 different reasons why one arm doesn't work as the other. But you don't get expertise. You don't know anything about your situation. And she saw the surgeon. He tentatively diagnosed the rotator cuff tear, got the MRI, and did surgery. And said at the end of the case, if you'd waited 3 more months, I probably could not have gotten the tendon back to the bone because the muscle would have contracted. That is expertise. That is what is available. So generative AI, different than the other forms of AI, and applicable directly in medicine to save hundreds of thousands of lives every year, to lower the cost of healthcare, to reduce clinician burnout. Why do these mistakes happen in medicine today? You know, as doctors, we like to figure out what's going on, and figuring out what's going on, we need to then figure out what we can do about it. And I want to point to two things, two very human things. The first reason is doctors don't have enough time. Nurses don't either. Clinicians don't. There was a study done that said that if the typical physician were to do everything recommended for every patient, it would take 27 hours a day. That is how much we could do. There's not enough time. We cut corners, not because we want to cut corners. We cut corners because we have no choice. And I believe that's a major reason why doctors go home at night unfulfilled. They knew they cut corners, and they hate it. Because when you cut corners, you make mistakes. You harm patients. A Nobel Prize was given for the work that was done on what's called cognitive biases. When you cut corners, you open yourself up to cognitive biases, confirmation bias. The typical physician takes 11 seconds before they interrupt the patient. They don't have time to get a full history. And after 11 seconds, they've come to a tentative diagnosis, and everything after that is confirmation bias, proving that their diagnosis is accurate. What we know is that there's a confirmation bias. Clinicians are going to believe they know more than they know because their only alternative is to get assistance, and that takes more time. We could go down these list of biases, but one big bias that comes out of all of this is that we are more forgiving and accepting of human error and very, very rigid and harsh in evaluating technological mistakes. The question we have to ask ourselves is not, is generative AI perfect? Not even is someone going to get possibly harm from it. But will it lower misdiagnoses from 400,000 down to 300,000, or 200,000, or 100,000, or 50,000? Not will it be perfect. How does it compare? And I want to speak a little bit later on about how we might compare these two pieces. Testing human against the computer and giving FDA approval when the computer is 10% better than the human at making accurate diagnoses and therefore saving lives and improving people. I want to stress one other thing before I give you some very specific examples of what I think will happen very soon. But you have to understand the structure underlying it all. First, you have the large language models, the ones I mentioned, ChatGPT, Claude, Gemini, DeepSeek. Actually, let's stay with the first three. These were developed exactly the way that I told you. They work independently. They can answer any question that is out there. The problem is if a patient uses it and has a difficulty, identifies a problem, what does the individual do next? They got to go see a doctor. They got to go make an appointment. They have to go back into the broken system that exists. So the generative AI tools are excellent at providing broad excellence, expertise, but what they don't do is they don't allow action to be taken. And this is where the second part comes, what I call a complementer. And the biggest complementer to generative AI is telemedicine. What's the problem? Why do we have, I'll call it slow uptake? Because we have to overcome, when it comes to medical care, time and distance. And the easiest way to overcome time and distance is in the doctor's office. But the best way, particularly for patients, is in the patient's home. If all you have is telemedicine and patients are trying to schedule telemedicine visits with doctors all the time, there's not enough time. Doctors have too many things to do to be spending their time doing telemedicine visits rather than seeing people in their office. But if all you use is a generative AI tool, you need to have a human to change a medication, to change something that is happening. The combination, a generative AI tool with 24/7 monitoring, and a telemedicine solution when a problem is identified, that creates now massive power. And the third area is what's called a derivative. These large language models are incredibly expensive to build. DeepSeek was created at a cost of supposedly $6 million. Let's just say it's a little bit more, far less than the hundreds of billions of dollars $6 billion, far less than the hundreds of billions of dollars that were required for these other models. In distillation, you take a current large language model, and rather than trying to scrape all the internet, all the information that's available, you ask it millions of questions, you create your own large language model focused on a particular area, and then you do additional training. How might that work? Imagine that you're going to create a tool specific for diabetes. You use a large language model, you distill it to get all the medical information. You don't really care about the art, you don't really care about the music, you don't really care about a lot of the things that might be in a large language model. You want all the information specific to medicine. You then want to use it to be able to create the foundation for how you take care of a patient with diabetes. And then you want to do additional training. You take all of the tapes that are done in an advice center where patients call with questions about diabetes. You take all the information from a chronic disease management program and you train it on those interactions. And after you've trained it on those interactions, learning from the nurses or the doctors or the clinicians who provide that information today, building it upon a foundation of generative AI, you do an experiment. The next 50,000 people who call in, or the next 50,000 patients that you call because they have a chronic disease, you ask them whether they'd be willing to be part of a research study. In this study, we're not going to tell you whether you're talking to a human or a computer. And, as we do always, we're going to record the conversation for quality review. And we then will bring in other experts, doctors, nurses, patients, who don't know whether the recording they're about to hear was done by a human or a computer, and evaluate the outcome. What happened to the patient? Did their blood glucose come down? Did their hemoglobin A1C improve, or did they not improve? And when it gets 10% better, 10% more reliable, 10% more accurate from the technology, which it will, by the way, then we give it FDA approval. Medicine is ripe for generative AI. I don't know how many of you have ever been in a hospital. Obviously, the clinicians in the room have been there, hopefully not as a patient. But there are all these monitors at every bedside, all the beeps that are going on. They generate a terabyte of data, 10 with 14 zeros after it. And with 97% of the data, we ignore it and throw it away. We use 3% of the data that those machines provide. And hospitals are totally chaotic situations. Multiple attendings coming by, seeing the patient, offering advice, nurses being unaware, no one talking to anyone else, no care being coordinated. It's exactly what a generative AI tool is able to accomplish. So let's look at some specific examples. As Mike said, I teach at Stanford Medical and Business School, and during the summer when the students are gone, the business school always has a variety of conferences. So last summer I was speaking to 80 CEOs from leading companies around the nation, talking about generative AI and how it might apply in their particular businesses. And at the end of the talk I gave, one of the people from the audience came up. He said, Dr. Pearl, I'd never used a generative AI tool. Well, my daughter had a very complex, difficult to diagnose problem, and I put her information into the application. Now remember, he said, for 18 months I traveled around the nation trying to figure out what she had. I went to 6 major, very famous medical centers. And finally, after 18 months, they made a diagnosis. ChatGPT gave me a 3-disease diagnosis. There at the top was the rare inflammatory disease that she had. That is what this tool is capable of doing. Just imagine, If you teach at a university, you have a medical student who knows everything in every textbook and every journal article ever written and never forgets anything. What would you do with that student besides hide him or her from everyone else so you could keep them on your staff? This is exactly what you would want. You'd recognize that that human being was going to be a lot smarter than you were and be able to give you answers that were more reliable. And how about for clinicians? I was talking to a very skilled surgeon. She was in the operating room. She did a very complex neck surgery. Bloodless. Nothing was going to be damaged. Perfect. At the end of the operation, the anesthesiologist says, we can't take the tube out. We can't extubate the patient. The vocal cords are adducted. They're sticking together in the middle. If I take the tube out, airway is going to be blocked. Should I take the patient to the ICU? Took out her phone. Asked ChatGPT what she should do. It found 4 cases of exactly the same phenomenon. Because occasionally in patients, the local anesthetic with adrenaline that we inject at the start of the case in order to prevent small blood vessel bleeding and keep the field dry spreads, for whatever reason, in some patients more than others. So even though she never went near the nerves to the larynx, to the vocal cords, they became blocked because of the anesthetic that had been administered. And in all 4 cases, after 30 minutes, it wore off. She said, no, let's just stay here for about half an hour. 20 minutes later, the cords separated. Patient went home. That is expertise. And I don't think very many doctors would say, keep the patient in the OR. I'm going to go to the library. I'm going to go research this subject, see if I can find a case and make a change to happen. Do not think about this tool as what exists today, although what exists today is incredibly excellent. But where I believe the greatest impact is going to come is going to be the area of chronic disease. Chronic disease is the scourge of this nation. 60% of people have one or more chronic diseases. They account for 70% of medical visits, 70% of medical costs. And I'm going to tell you a secret. We do a crummy job of managing them. I'm not even going to talk about preventing them, just managing them. A patient comes in to your office, they have hypertension. Hypertension accounts for 40% of all strokes. It's also a major contributor to heart disease and to kidney failure. But they have hypertension. You prescribe a medication. And what do? You say, okay, take the medication and come back in 4 months. After 4 months, they come back, blood pressure is still elevated. What do? White coat syndrome, come back in 4 more months. What happens between those visits, we have absolutely no idea. Across from the business school at Stanford is the engineering school. If you walked in there right now, you'd see they have tons of Band-Aid-sized monitors that are 99.999% accurate at measuring blood pressure, at measuring pulse, at measuring blood oxygen, blood glucose, or at least interstitial glucose. Again, I'll defy you. Find me a single physician who today is telling their patients to use one of these monitors. Why not? These monitors could measure blood pressure 3 times a day, let's say. So at the end of the month, after you prescribe this medication, you have 100 readings. 92 are normal, 8 are abnormal. How are you doing? I have no idea. I'm doing great. 92 are normal. I'm doing terribly. 8 are abnormal. And my next challenge to me, find me a doctor who wants to get 100 blood pressure readings every day from all the hypertensive patients in his or her practice. It's an easy first and second calculus derivative calculation. An AP 11th grader can figure it out. How do you tell whether the blood pressure is getting better or worse based upon an analysis of 100 numbers? So why don't we do it? Because we don't have the tool until now to accomplish it. Bluetooth connects, wearable monitors to a generative AI application. A generative AI application is constantly doing a calculation, and at the end of the month, you know the patient's not getting better. So now you as a clinician, using telemedicine, not in an office visit, change the medication, change the dose, change it to a different drug. Instead of being a year later and the blood pressure is still out of control, by 1 or 2 months later, it's back in control. Why do we use a hemoglobin A1C rather than a blood glucose to figure out how a patient is doing? Because we only want to see the patient every 3 to 4 months, and the hemoglobin A1C tells you exactly that. But what do you really want to know? How's their blood glucose doing? Are they getting better or worse? Diabetes, the leading cause of heart disease, kidney failure, 80% of peripheral amputations. How well do we manage hypertension? 55 to 60% of the time. 55 to 60% of the time. When I was CEO in Kaiser Permanente, we did it 90%. But how did we do it? We had a lot of nurses and pharmacists and other people following these patients. Very expensive. It worked in Kaiser Permanente because it's capitated. It does not work in the rest of medicine. Now we have the tool that does it for a matter of pennies to be able to do this calculation. It's not available yet right now. Why is that? Because when I talk to the CEOs at Apple or the CEOs at Google, they don't want to take the legal risk. They don't say that, but that's the reason why. That's why Apple's product released last week that they called Dr. AI basically tells you whether you're exercising and eating okay. It doesn't tell you anything about medicine. When they released the AFib monitor, who did they design it for? People who don't have AF, don't have atrial fibrillation. Why is that? The tool would be very useful if you have atrial fibrillation. They do it because then you have a medical legal risk. It is the legal risk that prevents us from doing the things that we need to do for the patients. It's not that the opportunities don't exist. It's the time that doctors don't have that leads us to allow patients to only have a 55 to 60% hypertension control. And by the way, diabetes we control even less often. You can go down all the places. Chronic heart failure. We know 2 to 3 days in advance who's going to be in the ICU and then in the hospital in 2 to 3 days from now. How do we know that? Because their ankles swell, they gain weight. They can't climb steps as well as they used to. Classic symptoms every second-year medical student can tell you about. And we don't monitor them. Maybe we tell the family to look for these things. We can measure them. We can know exactly what is happening. We can correlate that with diet. And we can figure out who's going to be sick in 2 to 3 days and prevent it from happening. Think inside a hospital. I don't know how many of you have ever been in a hospital. I've never been there for a bad medical problem, but I'm an avid skier. I've broken 13 bones, and I've spent some time having to have plates put in and other things happening to me. So I know exactly how nurses work. They come by at 8 o'clock in the morning, they see you, they check everything out, and they come back at noon. What happens between 8 a.m. and noon? No one knows. What we know is that once those monitors, once they ring, the patient is an extremist. Maybe it's a complete arrest. Maybe it's going to be just a severe deterioration. When was the problem first happening? 2 hours earlier, at 10 a.m. But no one knew because no one was checking those monitors. A generative AI tool can do it. Every doctor loves to have their patients on telly. In every hospital, the problem is it's very expensive and there are not enough monitors. Why do they want them there? Because they know what happens. They know you can identify these problems long before they become so severe that the patient's life is in danger. This is the opportunity to monitor, to tell the patients, nurses who to see. You see, we treat everyone essentially as a periodic number. We see people back in our office every 3 to 4 months. It's a calendar basis. We see patients every 4 hours. We don't figure out who is at greatest risk and spend a lot of time taking care of those individuals, maybe every half hour, even though they're not in an ICU. because we don't need to see the other people except once a day because the monitor is telling us they got better. It is this combination that this conference is about between technology and humans. Dedicated clinician working with an empowered patient and using generative AI will be 10 times better than any of them are today in a matter of 5 years. And we need to be ready to accomplish that. There are risks. Privacy, security, bias, and misinformation. Those risks are greater, however, in the narrow AI tools than generative AI tools. Why is that? What was the classic event happened 2, 3, 4 years ago when Optum, a subdivision of United Healthcare, was tasked a computer application to figure out who were the 200 patients in a particular geography at greatest risk of developing a major complication so that they could provide additional resources to help manage their chronic and ongoing diseases. The application did what I said earlier. They took the databases that existed, compared them, and identified a list of 200 people. Researchers then went into the company, and rather than finding that 15% of the people were black patients, which is what the application found, they found that 45% should have been. What did the headline scream? Computers, AI is biased, discriminates. No. All it did is it took the actual data from clinical practice where we know that when you take two patients, one is black and one is white in the United States today, and you compare the care they get, the black patient gets $1,800 less care. Not because they're less sick, because they get less care. That is the American healthcare system. And we don't pay any attention to it. Occasionally we mention it, maybe. We don't make any changes in that. So when the application does what it does in a narrow AI tool and duplicates it, we get the same outcome, amplified. That's where a generative AI tool will make a huge difference. Because it has been trained on everything. It's been trained on bias. And you can prompt it to say, please make sure that bias is not demonstrated. Please check to make sure that the care provided to patients who are black is as good as that as patients who are white. Please use expertise to accomplish that. Privacy is an issue, but who do you trust more not to sell your data, OpenAI or Google? It is Google's advertising model. That's how they make the money. When the CEO went in front of Congress, when Facebook CEO Mark Zuckerberg went in front of Congress, he was asked, how do you guys give this away for free? And he looked at them like, are you idiots? We advertise, we sell the data. That is the model that they use. And that's the agreement you make when you use their free tool. And security is a problem. Change Health demonstrated last year that bad actors, ransomware folks, can invade the healthcare system and destroy it, but it's no greater in a generative AI tool. I think the legal issues are going to have to be addressed. And when you look at these tools that I'm describing today, again, I want in your mind to separate out the large language models, the ChatGPTs, the Claudes, and the Gemini, from the derivative models, the ones that we specifically designed. Because in a large language model, the risk is actually very small. Why is that? Because it's so dependent upon the human factor. It's dependent upon the information that the clinician gives the patient and the patient enters into the system. If it's not accurate, what you're going to have is information that comes out that's not accurate. But that's not going to be OpenAI's fault, or Google's fault, or Anthropic's fault. But when you start providing specific tools, ones to help people manage diabetes, or ones to help people manage hypertension, or ones to be able to manage another chronic heart failure or another chronic disease, That is where the tools will have the impact. I want to give you one other example because this conference is so much about safety. And my first book I wrote, ChatGPT is my third book. The first book was called Mistreated, Why We Think We're Getting Good Health Care While We're Usually Wrong. And it began with the story of my dad who died for preventable medical error. Why do 250,000 people die in the United States every year now? And this is Johns Hopkins data, I'm not making any of this up, from preventable errors, particularly in the hospital. That's where most of them happen. By now you should know the answer. It's time. Time makes us cut corners. The data coming out of Johns Hopkins demonstrated that if you follow 5 or 6 different ways, when you place a central line, 5 or 6 different things when patients sit in the ICU and intubated so that the stomach acid doesn't have regurgitation go into the lung. When you do medication and you do the checking of the armbands and 2 nurses, etc., why don't we do it every single time? Because we don't have the time to do so. And if you look at the advances in generative AI over the past year, when I wrote ChatGPT, the data was 18 months in arrears. Today it's up to date. When I wrote the book, the only way to enter information was in writing. Now it's multimodal with voice and image. And now you start to see that in every room there's going to be a camera watching the clinician. And the clinician, when he or she forgets to stick the gown on, forgets to use the gloves, has whatever excuse is used today because there's not enough time to do the things the right way. It's going to stop that person before they take the action. Will clinicians like this? No. But if you're a patient, do you want it in your room? Yeah. The last thing you want is a preventable medical error, and that is going to be the heart of the challenge that exists going forward, which is that the clinicians are not going to embrace this the same way that the patient, if the patient had all the information, would. And they're not going to embrace it for 2 reasons. One is, as I said in the example in the hospital, they're not going to be happy being watched. But after a while, the research says you get over that. But the economics. And so if I could, Mike, add one last piece on top of all the other things that you have, I'm going to make the argument that we will never use this technology to save hundreds of thousands of lives and make care affordable and even reduce burnout unless we address the economics of it. Because if I look at what's the foundational problem in American medicine today, it's the fee-for-service method. Pay for volume. Charlie Munger said, tell me your incentives and I'll tell you the outcomes you're going to get. Pay someone fee-for-service, pay for volume, you'll get a lot more volume. But you're not going to get better outcomes. That's so counterintuitive, but it's the reality that exists. The reason we don't control hypertension better isn't because we don't know how to do it, isn't because we don't have the medications to do it. It is because the incentives tell us it's better to see 2 more patients than it is to be able to do the things that we know will prevent 40% of strokes in the United States today. That's the challenge. And if we can't move from fee-for-service to capitation, a single payment paid not to an insurance company, not like today, paid to doctors and hospitals, so that they are rewarded when they achieve better outcomes. So they get rewarded when the blood pressure is controlled, when the blood glucose is controlled. They get rewarded when they take care of a patient 2 days before the patient's hospitalized, rather than getting paid 100 times more to unblock the problem that happened in the first, that could have been prevented, that therefore happened. Until we move there, I have worries. And so in the 2 days that you're here, you're going to need to grapple with that. Grapple with the human challenges of using modern technology. Grapple with the challenges of how we're going to evolve the system. Because if the system of medicine, if the payment methodology doesn't align with what's best for health, the money will win out in the end. It's not because people are bad. It's just human nature. I want to again thank Michael for organizing this conference. Thank you for coming today, and I can't wait to hear all the recommendations that come out of this. Together we can make American medicine great. We can save hundreds of thousands of lives, make care affordable for all Americans, and reduce the burnout that is the plague of American medicine today. Thank you very much for inviting me.